structure in the tutorial. For now, we're just going to focus on this section of the digestive tract, that is the rectum, highlighted here, while the anal canal is this section in green just below. As you can see, the rectum and the anal canal are the final structures that make up the digestive tract, and they play important roles in the defecation of feces. There are quite a few structures to point out for each organ, so I'm just going to go through the structure of our tutorial for today. And of course, we're going to begin with the rectum and anal canal's function, structure, and location, followed by their arterial and venous supply, as well as their nervous supply. And of course, after that, we'll discuss the clinical notes before talking about the associated structures that you can see on this image of the rectum and the anus cut in coronal section. And of course, let's begin with the rectum. And the rectum is the last portion of the large intestine and the final stop before feces are eliminated during defecation. While we talk about it, let's just pop it out and put it into the center just here. And as you can see, the rectum begins at the end of the sigmoid colon at the rectosigmoidal junction and ends at the anorectal junction. The rectum begins at the level of around about S2 to S3 and is around about 12 to 16 centimeters long, with a diameter of around about 4 centimeters, and this diameter dilates distally. Similar to the colon, the rectum is responsible for absorption and absorbs electrolytes, that is sodium, potassium, and chloride, as feces pass through. And you can see the electrolytes moving out into the rest of the body in this little animation.
Or DARES. Firstly, why do we perform DARES? Well, it's primarily to detect possible early anal cancers. The fingertip is very sensitive and can feel something as small as a grain of rice. In comparison, anal cancers diagnosed at less than 1 centimeter in diameter typically have cure rates of 100%, so if we are able to diagnose cancers at an early stage, then the outlook for the patient is considerably enhanced. Who should have a DARE? Well, in essence, people at very high risk of anal cancer, and anyone from a risk group who develops new anal symptoms. This may include immunocompromised people, such as those with HIV, and transplant recipients, men who have sex with men, and women with a history of cervical, vaginal, or vulval HPV-associated disease. So it's important to realise that a digital anal rectal examination is different from the standard medical examination of the prostate. Firstly, we're examining 360 degrees of the anal canal, not just the anterior portion, which is done in a digital examination for prostatic changes. Secondly, we're extending up to 10 centimeters, the full length of the index finger, into the anal canal and detecting small abnormalities, primarily masses. And you can see this illustrated in the diagram here, where the area to be examined is highlighted in the yellow box. When you're performing a digital anal rectal examination, it's important to explain beforehand what you're going to do to the patient, explain why you're doing it and the individual components, and to ensure that the examination is conducted in a private, calm environment where the patient is unlikely to be disrupted by any other events happening locally. Once you have a patient, typically in the left lateral position, be patient. The external anal sphincter will relax within a few seconds, really, of introduction of a lubricated finger. It's important to reassure the patient that the anal canal is usually empty and that there's unlikely to be any fecal material. Once relaxed, insert a lubricated finger into the anal canal until you can feel the free space of the rectum. Typically, from the doctor's point of view, it's at his or her proximal interphalangeal joint. And just to remind you, you're palpating the whole length of the canal through 360 degrees, and this can take up to about a minute. I find it most helpful to palpate the posterior wall of the anal canal first, and then gently rotate the finger through 180 degrees on the patient's left-hand side, then change my position, and then palpate the anterior wall of the canal, checking the prostate, and then repeat if unsure. So this video demonstrates the performance of a digital anal rectal examination. You can see the first stage is getting adequate lube with local anesthetic and gently applying it to the perianal skin with a good light supply. Index finger is gently and slowly inserted into the anal canal, and then rotated through 180 degrees, examining the left lateral side, and then rotating back, just double checking to the posterior quadrant, and then rotating the finger through on the right hand side, and then popping back to double check the prostate in the anterior portion of the anal canal, checking for the presence of the median sulcus and for any abnormalities of the surface characteristics of the prostate felt through the anterior wall of the anus. Provided the reason for performing the dare has been fully explained to the patient and they're relaxed and comfortable, there should be very few problems performing this examination in an at-risk individual. The concerns for performing dares are really the false positives. Sometimes intraanal warts can give the appearance of a cancer. These generally are mobile and highly irregular. Hemorrhoids by and large are compressible and so don't present a mass, although occasionally if you have a thrombosed internal hemorrhoid that can be felt as a small, usually non-fixed or sometimes tender mass. Intraanal papillae can sometimes be detected, but they're very smooth, generally very mobile, and of course if someone's had scarring from previous surgery. So if there are any concerns raised by these findings, then it's really very important a more comprehensive assessment using proctoscopy is performed. Of greater concern are false negative dares. In other words, the examination is performed and a false reassurance given that it is negative. And I think the fundamental message here is that if there's any concern whatsoever, if you're unable to explain the cause of any symptoms, then it's very important to refer for more expert assessment if unexplained symptoms persist. Like any clinical technique, the more you perform it, the more likely you are to feel confident and be able to diagnose conditions. And again, if you're not confident, then always refer for expert assessment if there are any symptoms which are currently unexplained. Sometimes people choose to do a self-examination from the point of view of digital anal rectal examination, and this may be relevant for people who are at high risk of anal cancer. It can be performed in the left lateral position, as you saw in the video, or squatting. Typically, people will do this in the shower. The procedure is essentially the same as has been demonstrated. Take your time, use lots of lube, and the finger is inserted really to the knuckle. Rotated through 360 degrees, and any change noted from previous examinations. And if there's any concern whatsoever, seek professional advice. So in summary, digital anal rectal examination may be relevant to certain people at very high risk of anal cancer. It is easy to perform but requires practice. And most importantly, it is potentially life-saving, as it may lead to the early diagnosis of a cancer when treatment is highly likely to be entirely successful.
As well as a normal prostate, it features 4 interchangeable abnormal prostates.